Good morning. Today I would like to present you very important slides. The term of my presentation is acute coronary syndrome and myocardial infarction. First of all, epidemiology. If you know, cardiovascular diseases is a leading cause of death worldwide. There are many types of cardiovascular diseases, including coronary artery disease, cerebrovascular disease, and peripheral artery disease. Often, there are no signs of disease until a medical emergency, such as a myocardial infarction, occurs. In 2015, cardiovascular disease accounted for more than 17 million deaths worldwide. Coronary artery disease is equal to ischemic heart disease. Classification of ischemic heart disease and coronary artery diseases includes first, chronic coronary syndrome is a stable angina pectoris. Second, acute coronary syndrome, which divided into types: non-ST segment elevation acute coronary syndrome, stable angina, and non-ST elevation myocardial infarction. And second, ST elevation myocardial infarction. The main cause of ischemic heart disease is atherosclerosis of the coronary arteries. Anichkov, the Russian pathologist, first discovered the significance and role of cholesterol in atherosclerosis. His studies the first milestone in lipidology in discovering the role of cholesterol in atherosclerosis. So, acute coronary syndrome consists of first non-ST elevation acute coronary syndrome, which divided to unstable angina and non-ST elevation myocardial infarction. Second, ST elevation myocardial infarction. Pathophysiology of acute coronary syndrome includes several factors. First of all is disruption of unstable coronary plaque or erosion, intracoronary thrombus formation, occlusive in the most of cases ST elevation in myocardial infarction, and non-occlusive in case of non-ST elevation acute coronary syndrome. Coronary arterial vasoconstriction, gradual intraluminal narrowing, and increased myocardial oxygen demand produced by several conditions such as fever, tachycardia, thyrotoxicosis in the presence of fixed epicardial coronary obstruction. Now I will talk about non-ST elevation acute coronary syndrome in details. Evaluation includes clinical symptoms. Main symptom is pain, which occurs at rest or with minimal exertion, lasting more than 10 minutes. Relatively recent onset, for example, within the prior 2 to 4 weeks, a crescendo pattern. For example, distinctly more severe, prolonged, or frequent than previous episodes. When ECG plays an important role in evaluation for non-ST elevation acute coronary syndrome. On the slide you see normal ECG and pathologic ECG. Main signs are T-wave changes, T-wave inversion. Most of all, in any leads, ST segment depression. Significant ST depression is more than 1 millimeter depression in every leads, any leads. Biomarkers complement clinical assessment, and 12-lead ECG is a diagnosis, risk stratification, and treatment for patients with suspected ST elevation acute coronary syndrome. Measurement of the biomarker of cardiomyocyte injury, preferably troponin, is mandatory in all patients with suspected non-ST elevation acute coronary syndrome. cardiac troponins are more sensitive and specific markers of cardiomyocyte injury than creatine kinase, CK, and myoglobin. Elevated levels of any of these markers distinguish patients with non-ST elevation myocardial infarction from those with unstable angina. So, myocardial ischemia and acute myocardial injury or increased biomarker value is a criteria for acute myocardial infarction. In this case, non-ST elevation myocardial infarction. And differently, myocardial ischemia without acute myocardial injury, no increased biomarker value is the criteria of unstable angina. It is very important patients with normal or moderate levels of troponin at admission. Repeat tests of troponin levels, preferably high-sensitive assays of troponins. Repeat tests in 3 hours is indicated. And changes of cardiac troponin value with at least one value more than upper reference limit is clinically significant and may confirm non-ST elevation myocardial infarction. The high-sensitive troponin assays permit a more rapid, in 1 hour, to rule in or rule out myocardial infarction determination. So, repeat tests of biomarkers for most of patients with acute coronary syndrome is indicated. On these slides, cardiac and non-cardiac causes of an elevated troponin. So, not always small elevation of troponins is a myocardial infarction. In patients with unclear history, small elevations troponin, especially if they are persistent, may not be diagnostic of an acute coronary syndrome. In such cases, both cardiac and non-cardiac causes of an elevated troponin should be considered. On this slide, a lot of other reasons for small, moderate troponin elevation. It may be arrhythmia, congestive heart failure, other cardiac diseases, non-cardiac, a lot of non-cardiac diseases such as trauma, sepsis, stroke, a lot of reasons. So we should always should estimate troponin with dynamics and should consider clinical presentation. Additional evaluation for non-ST elevation acute coronary syndrome includes several tests. Patients who remain pain-free with negative biomarkers such as troponin may proceed to stress testing, preferable for stable, low-risk patients to determine the presence of ischemia, or it may be used for coronary computed tomographic angiography to detect coronary luminal obstruction. Patients with documented acute coronary syndrome exhibit a wide spectrum of early risk of death, ranging from 1 to 10%, and the risk of recurrent acute coronary syndrome rate from 5 to 15% during the first year after acute coronary syndrome. So, it's extremely important to estimate the risk for each patient with acute coronary syndrome. Risk of complications, deaths, and recurrent acute coronary syndrome. We estimate risk for treatment strategy. Two main treatment strategies exist. First, invasive, early invasive strategy, and non-invasive or selected invasive treatment. Percutaneous coronary intervention (PCI), effective method of treatment but patients may have post-procedural, peri-procedural risk. We should know which patients will have favorable results after PCI. High-risk patients have favorable results after PCI. For risk stratification, we estimate troponin level, ECG, clinical and comorbid factors. Exists special scoring system. For example, GRACE scoring system. On the slide you can see a screenshot of GRACE calculator. GRACE calculator is very clever and effective tool for risk assessment. Patients with acute coronary syndrome with elevated levels of troponin and with high risk, calculated estimated high risk, are considered to have non-ST elevation myocardial infarction and have less favorable, worse prognosis. They are candidates for early invasive treatment. Differently, patients with acute coronary syndrome without elevated levels of troponin and low risk are considered to have unstable angina and have a more favorable prognosis than those with ST elevation, and they may be treated without early invasive strategy. Following initiation of anti-ischemic, anti-thrombotic agents, coronary angiography is carried out within 24 hours of presentation, followed by coronary revascularization, PCI, or in some cases coronary artery bypass grafting. Is dependent on the coronary anatomy. Multiple clinical trials studies have demonstrated the benefit of this strategy in high-risk patients. For example, patients with multiple clinical risk factors, ST segment deviation, and positive biomarkers. And in patients at low risk, the outcomes from the invasive strategy are similar to those obtained from a conservative medical strategy. Where to treat patients with acute coronary syndrome? On the slide, photo of coronary care unit or cardiac care unit. This is a room. The cardiac care unit may ensure monitoring for complications in patients with acute coronary syndrome. Patients with acute coronary syndrome initially need bed rest with continuous ECG monitoring for ST segment deviation and cardiac arrhythmias. Treatment of acute coronary syndrome, non-ST elevation acute coronary syndrome, includes several levels. First, relief and prevention of recurrence of ischemic discomfort or pain. Inhaled oxygen in patients with arterial saturation less than 90%, and or in those with heart failure and rales in lungs. Beta adrenergic blockers, antithrombotic therapy, and lipid-lowering therapy, and additional medical therapy, ACE inhibitors or AR blockers. Treatment, first, treatment, how to relieve and prevent of recurrence of ischemic discomfort, pain. First of all, is nitrates, sublingually or buccal spray of nitroglycerin. If symptoms persist after 3 doses given 5 min apart, nitroglycerin intravenously may be prescribed the dose may be increased every 3-5 minutes until symptoms are relieved, or systolic arterial pressure falls to less than 90 millimeters, or the dose reaches 200 microgram per minute. Oral nitrates such as isosorbate D-nitrate or mononitrate replace intravenous nitroglycerin when symptoms-free period is more than 12 or 24 hours. If nitrates are ineffective, morphine 10 milligram intravenously bolus should be used if nitrates are ineffective. Then beta-adrenergic blockers are the mainstay of anti-ischemic treatment, where they may be started by the intravenous route in patients with severe ischemia, but should be avoided in the presence of acute or severe heart failure, low cardiac output, hypertension, or other contraindications to beta blockers therapy. Metoprolol 5 milligram intravenous bolus first may be prescribed when metoprolol in tablets 50 milligrams with titration should be prescribed. Instead of metoprolol, atenolol, carvedilol, or propranolol may be prescribed. Targeted heart rate for beta blockers therapy is from 50 to 60 beats per minute. Antithrombotic therapy is very important treatment. Remind you, the pathophysiologic factor of acute coronary syndrome is unstable plaque, so antithrombotic therapy is indicated. Antithrombotic therapy includes first antiplatelet drugs and anticoagulants. First, antiplatelet drugs. Aspirin, at least 100 milligram of a rapidly acting preparation, then lower doses, 75 to 100 milligram daily, and additionally to aspirin we should prescribe the second antiplatelet agent. It is P2Y12 inhibitor, as may be prasugrel or ticagrelor or clopidogrel, any of these P2Y12 inhibitors. Dual antiplatelet therapy is a standard therapy for acute coronary syndrome, and it should be continued for at least 1 year in patients with non-ST elevation acute coronary syndrome. On these slides, the results of COMET study, very big study. Results of the study show dual antiplatelet therapy is more effective in prophylaxis of death, recurrent myocardial infarction. Then anticoagulants agents. We can use one of the several anticoagulants. First, fractionated heparin. It may be used intravenously, both 100 units, international units per kilogram. Then infusion. We should control laboratory tests, ACT. It's maybe some problem to control. laboratory tests. Anticoagulant agents have different mechanism of action, so unfractionated heparin action as a multifactorial agent, will have poor control of action. Another anticoagulants, such as low weight heparins, have better characteristics. Low molecular weight heparin, such as enoxaparin, is anticoagulant agent, which is more convenient in use. Enoxaparin is prescribed as 1 milligram per kilogram subcutaneously every 12 hours. The first dose may be preceded by 30 milligram intravenously. Then the indirect factor 10A inhibitor fondaparinux 2.5 milligram subcutaneously daily, which is equivalent in efficacy to enoxaparin but has a lower risk of major bleeding. Another anticoagulant, bivalirudin, a direct thrombin inhibitor that is similar in efficacy to either unfractionated heparin or low weight heparin, enoxaparin, but causes less bleeding and is used just prior to and or during PCI. Next treatment agent is lipid lowering therapy. Modern treatment strategy, as less is better. We should decrease cholesterol level at patient with acute coronary syndrome. The main goal of therapy with lipid lowering drugs is to decrease less than 50% in cholesterol from untreated baseline and decrease the low density lipoprotein cholesterol less than 1.4 millimole per liter. Has been shown to reduce periprocedural myocardial infarction and recurrences of acute coronary syndrome. Lipid lowering therapy includes first statins. It may be atorvastatin or rosuvastatin in high doses. For atorvastatin is 80 milligram daily. For rosuvastatin 40 milligram daily. Combined lipid lowering therapy may be prescribed if there are failure to reach the treatment goal and reduce the cholesterol. Additional therapy with ezetimibe 10 milligrams daily and or inhibitors of PCSK9 receptors alirocumab, evolocumab, which we can prescribe every 2 weeks or 4 weeks. This is very convenient for patient and very effective. Combined lipid lowering therapy is a very effective therapy in decreasing cholesterol level and in reaching the treatment goal for cholesterol level. Additional medical therapy includes ACE inhibitors or sartans, several medical agents, drugs on the slide, ramipril, lisinopril, zofenopril, and sartans such as valsartan or losartan may be used for additional medical therapy This therapy is very important, especially for patients with heart failure and myocardial infarction. Another special form of acute coronary syndrome is Prinzmetal's variant angina or vasospastic angina. It's a special form of acute coronary syndrome. Why? Usually it occurs at rest and is associated with transient, not sustained, transient ST segment elevation. The reason is a focal spasm, vasoconstriction of a coronary artery, and it may lead to acute myocardial infarction, different arrhythmias such as ventricular tachycardia or ventricular fibrillation, and sudden cardiac death. Patients with variant angina are younger, and with the exception of smoking, have fewer coronary risk factors than do patients with other forms of non-ST elevation acute coronary syndrome. The clinical diagnosis of variant angina is made by the detection of transient ST segment elevation with rest pain. Coronary angiography demonstrates transient coronary spasm as a diagnostic hallmark of angina. Atherosclerotic plaques in at least one proximal coronary artery occur in about only half of patients. Treatment of variant angina includes nitrates and calcium channel blockers are the main therapeutic agents. Aspirin may increase the severity of ischemic episodes. Statin therapy has been shown to reduce the risk of major adverse events. The response to beta blockers is variable. Beta blockers may induce spasm. Coronary revascularization may be helpful in patients proximal fixed obstructive lesion. Patients who have had ventricular fibrillation should receive an implantable cardioverter defibrillation ICD. Okay, now another form of acute coronary syndrome is ST elevation myocardial infarction or STMI. Evaluation for ST elevation myocardial infarction includes estimation of clinical presentation, again pain. Pain during ST elevation myocardial infarction usually is deep, visceral, heavy, squeezing, crushing. Occasionally it is described as stabbing or burning. Occurrence of pain at rest is usually more severe and lasts longer, more than 20 or 30 minutes. It is often accompanied by weakness, sweating, nausea, vomiting, and anxiety, and a sense of impending doom. The proportion of painless ST elevation myocardial infarction is greater in patients with diabetes mellitus, and it increases with age. In the elderly, STMI may present as sudden onset breathlessness, which may progress to pulmonary edema. Other less common presentation with or without pain include sudden loss of consciousness, confusional state, a sensation of profound weakness, the appearance of an arrhythmia, evidence of peripheral embolism, or merely an unexpected drop in arterial pressure. STEMI has much more signs than non-ST elevation acute coronary syndrome. If you see on this slide, a lot of physical signs. It may be restless, pallor associated with perspiration, the coolness of extremities, the combination of substernal chest pain persisting for more than 30 minutes, and diaphoresis strongly suggest ST elevation myocardial infarction. About 1/4 of patients with anterior infarction have manifestation of sympathetic nervous system hyperactivity, tachycardia, and/or hypertension, and up to 1/2 with inferior infarction show evidence of parasympathetic hyperactivity, bradycardia, and/or hypotension. The precordium is usually quiet, and the apical impulse may be difficult to palpate. Fourth and third heart sounds, decreased intensity of the first heart sound, and paradoxal swapping on the second heart sound. Temperature elevations up to 38 febrile fever may be observed during the first week after ST elevation myocardial infarction. In most patients with ST elevation myocardial infarction, transmural infarction, systolic pressure declines by 10 to 15 millimeters from pre-infarction state. ECG is very important, is extremely important method of evaluation for STMI. How to measure ST elevation? If you see on the slide, the initial onset of the Q wave shown by arrow 1 serves as the reference point, and arrow 2 shows the onset of the ST segment. Arrow 2 shows J point. The difference between the two identifies the magnitude of displacement. Measurements of both arrows should be made from the top of the ECG line tracing. So, we should measure ST elevation at J point. ECG sign at ST elevation myocardial infarction is ST elevation at the J point in two contiguous leads, 1 or more millimeters in all leads other than leads precardial 2 or 3, where following cut points apply 2 or more millimeters in mean 40 or more years, and 2.5 millimeters in men less than 40 years, or 1.5 or more millimeters in women regardless of age. Very important slide. Patients ECG with ST elevation myocardial infarction have elevation and depression. So on the ECG you will see S elevation and depression. ST elevation is primary sign, reflects primary processes of myocardial injury. ST depression is annular ECG sign, it's secondary process. Elevation on the ECG steady patient is primary changes. ECG reflects pathology of coronary arteries. Each lead suits match to coronary artery. Heart normally has two coronary arteries. Left coronary artery have left main, which divided into branch. left anterior descendant branch and circumflex branch. Right coronary artery RCA have several branches too. On this slide you can see a scheme of the coronary arteries, and at the right part of the slide you can see results of coronary angiography, and at upper right part you can see left coronary artery with left main artery with left anterior descendant LAD with left circumflex artery. On this slide you can see normal coronary arteries. In right part of the slide you can see right coronary artery, normal right coronary artery as a result of coronary angiography. Due to myocardial localization, myocardial infarction is classified as anterior, inferior, lateral, and posterior myocardial infarction. So, anterior myocardial infarction matches to left anterior descendant artery zone to blockage thromboocclusion of LAD artery. This process lead to anterior myocardial infarction, ST elevation myocardial infarction. With anterior myocardial infarction matches to several ECG leads. You can see ST elevation precardial V1 to V6 leads. Inferior wall ST elevation myocardial infarction. Inferior myocardial infarction matches to right coronary artery or sometimes circumflex artery occlusion, and matches to several leads on the ECG. You can see on the ECG elevation at 2, 3 AVF leads. Posterior wall ST elevation myocardial infarction matches to also right coronary artery and circumflex artery, and you can see on the ECG ST depression at V1 to V3 leads and ST elevation at additional leads. In case of posterior myocardial infarction, we need to estimate additional leads V7 to V9. Biomarkers are also a criteria of ST elevation myocardial infarction, but biomarkers in case of STEMI are less important for treatment decision. In practical terms, biomarkers troponin assays are of less immediate value in patients with ST elevation myocardial infarction. Due to rapid cell deaths, cardiomyocyte cell deaths, we should make fast decision. Contemporary oxygen reperfusion strategies necessitate making a decision before the results of blood tests have returned from the laboratory, based largely on a combination of clinical and ECG findings. Clinical symptoms plus ECG findings, ST elevation are criteria and are criteria for treatment decision. Additional evaluation for ST elevation myocardial infarction, such as echocardiography, MRI, may be useful but useful for risk stratification and searching for complications. All decisions should be fast. We have algorithm for strategy, diagnostics and treatment. Saving minutes, adding life. All as decisions should be very fast and right. Like a relay, fast, exact, no mistakes at each player's patient call, pre-hospital care, hospital care. All decisions should be fast. Again, saving minutes, adding life. As you know, the cause of ST elevating myocardial infarction is acute thrombotic occlusion of coronary artery. So, reperfusion therapy is main treatment modalities for ST elevation myocardial infarction. Reperfusion is a treatment to restore blood flow at blocked coronary artery. Reperfusion therapy may be as primary percutaneous coronary intervention, PCI, again PCI, fibrinolysis, and PCI in addition to fibrinolysis. What about PCI? PCI appears to be more effective than fibrinolysis in opening occluded coronary arteries. Compared with fibrinolysis, primary PCI is generally preferred when the diagnosis is in doubt, cardiogenic shock is present, bleeding risk is increased, or symptoms have been present for at least 2-3 hours, then the clot is more mature and less easily released by fibrinolytic agents. For PCI, we need, of course, equipment and trained personnel. Is a problem. We need equipment and trained personnel. PCI appears to be more effective in restoring blood flow in coronary artery and reperfusion in myocardial tissue. Fibrinolysis is a medical reperfusion therapy with special fibrinolytic agents. Fibrinolytic therapy should be initiated within 10 minutes of diagnosis. Administer as soon as possible up to 12 hours after the onset of chest pain. Preferred at pre-hospital care. Fibrinolysis increases the risk of bleeding. So, patients may have contraindications. On the slide, absolute contraindications to the use of fibrinolytic agents. First, a history of cerebrovascular hemorrhage at any time. A history of ischemic stroke or other cerebrovascular event within 6 months. Central nervous system damage or neoplasms or arteriovenous malformation. Recent major trauma, surgery, head injury in 1 month, gastrointestinal bleeding within the past months, suspicion of aortic dissection, active internal bleeding excluding menses, non-compressible puncture in the past 24 hours, for example, liver biopsy, lumbar puncture. In these cases, the fibrinolysis is contraindicated and PCI is the optimal method of treatment myocardial infarction. Relative contraindication to fibrinolytic therapy, which requires assessment of risk to benefit ratio. In these cases, we can use fibrinolytic therapy is benefit of this treatment is clear. Relative contraindications include current use of anticoagulants, cardiopulmonary resuscitation, known bleeding diathesis, pregnancy, hemorrhagic ophthalmic conditions, active peptic ulcer disease, advanced liver disease, infective endocarditis, and a history of severe hypertension that is currently adequately controlled. Which fibrinolytic agents we can use? You can see three medicines, three drugs which we can use for fibrinolysis. First, alteplase, tissue plasminogen activator. The regimen of this agent is 15 milligram bolus, followed by 50 milligrams intravenously of the first 30 minutes, followed by 35 milligram of the next 60 minutes, and streptokinase may be used for fibrinolysis as fibrinolytic agent. 1.5 million units intravenously over 1 hour, and tenecteplase is the most effective and the most convenient in use fibrinolytic agent, a single weight-based intravenous bolus over 10 seconds, very fast and effective. Any of these fibrinolytic agents we may use to treat patients with ST elevation myocardial infarction. Again, where to treat patients with acute coronary syndrome with ST elevation myocardial infarction? Again, in cardiac care unit. Cardiac care unit may ensure monitoring for complications. Patients with ST elevation myocardial infarction initially need bed rest with continuous ECG monitoring for ST segment deviation and cardiac arrhythmias. Medical treatment includes again relief and prevention of recurrence of ischemic discomfort, pain, inhaled oxygen, beta-adrenergic blockers, antithrombotic therapy, lipid-lowering therapy, additional medical therapy. Again, nitrates very effective to relieve and prevent of recurrence of ischemic discomfort. Maybe sublingually or intravenous nitrates, nitroglycerin, without if we should control blood pressure and in absence of contraindications, this is very effective agent. If nitrates are ineffective, morphine 10 milligram intravenously should be used. Beta blockers again, metoprolol first intravenously 5 milligram, then in tablets with titration from 50 milligram daily to 200 milligram daily. Instead of metoprolol, it's maybe atenolol, carvedilol, and propranolol in doses. You can see on the slide doses of these agents. Targeted heart rate the same, 50-60 beats per minute. Antithrombotic therapy, very important therapy. If you know, antithrombotic therapy also is very important. Remind you the pathophysiologic factor of acute coronary syndrome is unstable plaque, so antithrombotic therapy is indicated. First, antiplatelet agents, aspirin, at least 100 milligrams when lower doses, 75 to 100 milligram daily, and additional antiplatelet agent P2Y12 inhibitor. Patients with primary PCI or elective PCI need to be treated with potent P2Y12 inhibitor. Prasugrel or ticagrelor preferred at PCI. Clopidogrel may be used, but clopidogrel has less effectiveness in prophylaxis of thrombotic complications. So, in patients which treated with PCI, prasugrel or ticagrelor is preferred. Again, dual antiplatelet therapy is standard therapy for any form of acute coronary syndrome, and ST elevation myocardial infarction as form of acute coronary syndrome should be treated with dual antiplatelet therapy for at least 1 year. Anticoagulants also very important for patients with ST elevation myocardial infarction. Very important, we should stop anticoagulation after successful percutaneous coronary intervention. If patient is treated without PCI, anticoagulants should be prescribed for 5 or 7 days, but if patient is treated with PCI, anticoagulation should be stopping. Again, we can use several anticoagulants. Unfractionated heparin bolus, 70 to 100 units per kilogram, maximum 5,000 units intravenously, then infusion of 12 to 15 units per kilogram per hour, initial maximum 1,000 units per hour, titrated to activated clotting time 250 to 300 seconds. So we need to control laboratory test activated clot time. It's maybe more difficult to treat patient with unfractionated heparin. Low molecular weight heparin, such as enoxaparin, does not need laboratory test control, and treatment with enoxaparin more convenient. Enoxaparin is prescribed 1 milligram per kilogram subcutaneously every 12 hours, and the first dose may be prescribed by 30 milligram intravenously bolus. Fondaparinux 2.5 milligram subcutaneously daily, equivalent in efficacy to enoxaparin, but has a low risk of major bleeding. And again, bivalirudin, initial intravenous bolus, and when infusion. Lipid lowering therapy also very important in treatment patient with ST elevation myocardial infarction. The main goal, the same goal of treatment with lipid lowering agents is to decrease less than 50% in cholesterol from untreated baseline level, and decrease low density lipoprotein cholesterol less than 1.4 millimole per liter. What agents we can use for lipid lowering therapy? Again, statins, high doses of atorvastatin or rosuvastatin. For atorvastatin is 80 milligram daily. For rosuvastatin is 40 milligram daily. In case of ineffective lipid lowering therapy with only statins, we may use combined lipid lowering therapy, statins and additional agents such as ezetimibe, 10 milligram daily, and or inhibitors PCSK9 receptors, alirocumab, evolocumab. This is very effective lipid lowering agents, and this treatment may be done in case of failure to reach the treatment goal and reduced low density lipoprotein cholesterol. Additional medical therapy, again, ACE inhibitors such as ramipril, lisinopril, or zafenopril, maybe sartans, valsartan, losartan. This therapy is effective to not only for blood pressure control, but this therapy is very effective for treatment heart failure, prophylaxis of complications of heart failure, acute and chronic heart failure. Very important slide. Patients with myocardial infarction require hemodynamic assessment. They may have acute heart failure. A classification generally proposed by Kirov divides patients into 4 groups. Kirov classification, class 1, no signs of pulmonary or venous congestion. Class 2, moderate heart failure as evidenced by RELs at the lung basis as free help, tachypnea, or signs of failure of the right side of the heart, including venous and hepatic congestion. Class 3, severe heart failure or pulmonary edema. And class 4, shock with systolic pressure less than 90 millimeters and evidence of peripheral vasoconstriction, peripheral cyanosis, mental confusion, and oligoria. Patients with myocardial infarction may have complications. At slide you see a list of possible complications: cardiogenic shock, ventricular tachycardia and fibrillation, accelerated idioventricular rhythm, sinus bradycardia, atrioventricular and intraventricular conduction abnormalities, pericarditis, thromboembolism, left ventricular aneurysm, ventricular septal rupture. We review them at practical lessons. Thank you for your attention.